Journal Club just ended.
Hi. Let's see. Did you have to like log off yours and then log back on, Mary?
It just that ended, and so as soon as it ended, which is right away, I just logged on to this one.
Okay. Yeah, I had logged off because I was like just trying to get everything organized and then um just wasn't sure how it was gonna work. Um and we are waiting for friendship people. I'm actually Ray, were you the one that was the primary on this case? The Lucy Wolf? It's recording already. Okay. As people are starting to join, there was a journal club immediately before this on our Zoom, on the Zoom account. This is the ACVNU Zoom account. And so uh, some people are quickly getting a quick break between that journal club and then joining this. But it is currently recording. And that reminds me, I probably need to make sure that I'm connected to the VPN for Texas A&M. Okay, and we're waiting for them to join. Let's see what else I need to do. Okay. And actually one thing I can do before all this starts is similar to those of you that joined at uh for the journal club, we do have a couple poll questions for for this meeting. That's the poll EV if you want to join that. I think there's only 4 questions, but there are a variety of questions for us to figure out the best way to have interaction between the participants. And JD, I see that you are here. Do you know if what happened was Dr. Skinner had volunteered the intern or the other resident to present the case?
Yeah,
And I
I
just
think
don't.
is here and ready, right? I'm staring at the back of his head. Yeah. He's giving me the thumbs up. Mario's here. He's
Got it. Okay.
eager and excited to present for sure.
Okay. I wasn't sure which one because I know you two, you have your own residence and then they have their own, like it's like a pyramid scheme there, pretty much,
It
right?
is. It's a big Ponzi scheme that we have here for sure.
Yes, we are recording, so maybe we shouldn't joke about that. Okay, so
Legal Ponzi scheme. It's a legal Ponzi scheme.
for those of you that have participated or been to kidney rounds, we're trying to find better ways to have interaction. So before we get started, I do a few little housekeeping points of order. And there is in the chat a poll EV link. It'll also should hopefully launch as a QR code for those of you who just want to take a picture with your phone and vote. I think only one question you can't vote with your phone. I think you have to have a laptop running, but it doesn't matter. We'll just see how it works. It's more of just a way for us to interact with people. The distribution list for these invitations. Anyone is welcome that's interested in kidney, internist, pathologists. Even if you are an internist at a vet school and you know your pathologists don't get a lot of kidney biopsies, they might want to attend and see more histopathology for kidneys. So the trainees, everyone's welcome. I do my best to add to everybody to the list. Currently, the distribution list goes out to about 150 people, and we get about 25 to 30 that attend, depending, partway through or all the way through the rounds. They are recorded, they are saved and archived and uploaded to the ACVNU site. I always say that very haltingly because I'm never actually sure what the site is. But they are stored in case you want to go back and look at some pictures or quiz yourself or something like that. Or look at a case. And then if you want to add people, just send me their email addresses. I think, Mary, I still have a couple people that didn't get added because Outlook was being weird. So I need to remind myself to add them again. And then the other thing is Outlook decides to delete emails from the distribution list for no rhyme or reason. So if you've noticed you haven't gotten any invitations over the course of like a month or two, the invitations always go out. We may not always have rounds, but they always go out somewhere in some way, shape, or form to see if people want to have rounds. So if you haven't even gotten a request for cases, for a couple months, email me back. Make sure that your email hasn't accidentally been deleted from the distribution list. I always tell the story. Dr. Hokamp herself has been deleted from the distribution list, and none of us know why. So it has nothing. It's no judgment against you. It's just that sometimes Outlook decides not to be friendly. With that, today we have a case that has, I think. I'm not sure, Mario, do you have stuff to present? I have a couple, all I have for quiz questions are a couple of PowerPoint slides, but if you're going to present first, then I can launch my questions after.
Yeah, I have a small presentation.
Okay. You should, let's see, are you able to share or not? Let me see if I need to give you sharing permission. Yeah, you should be able to share.
Here, let me see if I can share this. Mm. Mm.
I'm not seeing anything yet, so.
No, I'm just having some trouble with like with the settings. Let me see if I can troubleshoot this from my end.
Well, I'll give everybody a little bit of a blurb so we don't have some dead space here. This doesn't end well. So it is an autopsy case, but it reminds me to tell you guys that a lot of times, yes, there might be cases you don't have the opportunity or the financial means or the stability, the patient's not stable enough to biopsy. And so a lot of times you may not really know what you're working with as you're treating the patient. And if it is these types of interesting cases, which are really just, this is a very interesting presentation, reach out to us and we can figure out what steps we might do to help you diagnose it post-mortem. We may not do all the steps. Oftentimes we choose not to do EM because it's so expensive. But if you reach out to Dr. Nabedy, myself, or Dr. Hokamp, we can at least get you on the right road so we could get the best diagnostics for this case. So I can see stuff now.
Oh, okay, perfect. Sounds good. That was going to be my next question. All right, so we can get started. So this is just a case that I had the opportunity to work on with the nephrology service here at Friendship. And our story begins with a kind of 10-year-old female spayed domestic short hair that was transferred to us as an emergency referral. Initially, her story is a little bit odd because she was previously being managed by her primary care veterinarian, and particularly was initially for a concern of CKD that started to be progressive according to the primary veterinarian. And I have some other further lab data to show kind of her values initially. But then she came into us because she was actually presented to another emergency facility for suspicion of having ingested ibuprofen. And then after kind of further inquiring the owner and really going into the roots of it, the ibuprofen really was a red herring overall. But then during the emergency visit, they kept her on IV fluids, and just kind of more supportive care medication. And despite her kind of bright and alert clinical status, her azotemia continued to progress. And hence at that point, they recommended for her to come see us through the urgent care service, and of course, kind of as a transfer to the nephrology service. Before all that, once we received her records and reviewed everything, we were able to take a look at her previous urine values as well as her chemistry and CBC, which I'll kind of skip to that slide overall. I made a compilation of her clinical path data, starting from 2022 to all the way to kind of 2025. Unfortunately, I kind of mistyped that last number on the data. It's actually 1/22/25, but this is gonna just a brief view of what was performed. She also had some other additional testings that I don't think particularly are quite pertinent for the case, but I'll just mention them. It is kind of like a PTH panel, because at one point she had a transient hypercalcemia, and then an echocardiogram for assessment of her heart murmur. But even before she started becoming asymptomatic and really presenting to us, she had kind of signs of a glucosuria, at least of the dipstick, with a normal peripheral glucose, at least just based on the chemistry that was sent out. And then some signs of proteinuria, which initially was just being monitored by the primary veterinarian. And then as we kind of reviewed everything, we noticed that this was much more historic than we realized. And she's had been going on with some form of, at that point, our main suspicion was for a tubulopathy of some kind. We just weren't quite sure what sort of we were dealing with. But as you can see, kind of her azotemia when we first saw her, which was on December 30th, who had progressed quite rapidly from the 2.4. And even since then, like it had sort of slowly kind of crept up by that point as well. She also had a persistent proteinuria that was always within the 0.7 to 0.6 overall. And then the other piece of data I want to give you guys is that with her blood gas assessments here at Friendship, she always had a sort of a mixed disturbance, primarily more of a high iron gap metabolic acidosis, where her bicarb range all the way from 9 to 13. Her base excess was much lower, of course, kind of like -18 to -16. And then her high iron gap was 28 to 31. And so during her first hospitalization, we mainly just established that care with the owners and adjusted her treatments overall. And then finally, since she clinically was stable, we transitioned her to outpatient care, which mostly involved kind of focusing on that proteinuria with a renal diet, making sure that we sort of made a follow-up plan with her to recheck those renal values. And then basically from our end, trying to figure out other things to address in terms of supplementation if these were needed, or to the point of maybe establishing parts of the Gondo protocol that was used in Fanconi patients overall. One of those diagnostics that we ran on her was an SDS page, and these are kind of the results. And I put on the gel image as well that was sent to the renal path lab at Texas. The results did indicate that there was some form of kind of tubular damage or dysfunction per se. Most of the protein that was being seen was tubular in nature. And I think we'll probably speak more about this in the presentation, but in general, they couldn't really rule out some glomerular component. And generally throughout all this time, despite her azotemia increasing, she was doing fairly well at home. You know, she was still bright, alert. She was eating normally, still being interested in her food and very amenable to diet change overall. And then around kind of January time, I believe it was kind of the 14th or 15th, she represented again to the urgent care because she just acutely fell ill. At that point, just to sorry to jump from another slide to one, but just to go back to her clin path data, her azotemia had markedly progressed all the way to 13th. To try to manage her as an outpatient basis, we talked to the owners about placing an e-tube and then further addressing potentially that like long-term low base excess that we were seeing, or basically the acidemia itself. And so we put her under anesthesia and placed an e-tube overall, and she generally recovered pretty well.
Yeah.
But then once we discharged her and the owners brought her home, the owners just weren't comfortable with further management. And at that point, she also kind of failed that transition. So once we took her off her IV fluids, she just wasn't able to cope well with outpatient care. And at that point, the owners decided to euthanize. We did discuss potentially pursuing something like dialysis as a bridging the gap, but we figured out how to address her tubulopathy itself, but the owners didn't want to put her through that, and she was euthanized on the 24th.
Okay, so in an interesting case, interesting clin path, and obviously we're going to show you the histology as well and the electron microscopy. So are there any questions from everybody at this point? Okay, I'm going to start with a quiz question. Let's see if this works. I'm going to replace Clarence share with desktop. Maybe. Let's see if this works. Okay, you should be seeing.
Was a person. I said a boredom was a person.
Okay, so you guys hopefully are seeing a desktop. And are you guys seeing something that says Nephropathology clin path rounds, clinical consultation rounds?
Yep.
Okay, cool. We will see if this works with my next slide. So this is just a word cloud to see what you guys the question is what characteristics, if you guys can type into your phone or into your computer, here is the text, here is the poll link. What qualifications do you use or terms do you associate with the word tubulopathy? And I'll give you about like, I don't know, 30 seconds. And Hocamp, if you can type something in so I know it's working.
Okay.
Sometimes she doesn't participate.
I gotta get it. I gotta get it connecting.
Okay. Okay. It's doing it live.
It's
This is awesome.
working
This is even worse than, sorry, even worse. This is better than what we did in real week.
for real.
Okay.
Well, we know it's
so it does
working
it
then.
usually takes like about like it kind of checks in every 15 seconds to see what other things people have added. But glucosuria is a good term that we often think of for tubulopathy. Anything else? Casts, okay. Okay, metabolic acidosis. I don't know why it split that, but that's probably just for design study persons. And honestly, I'm not a clinical pathologist. Does tubulopathy always imply metabolic acidosis, or is it just something that's occasionally seen with it? I'm asking that as a group question.
I wouldn't say always.
Okay. And you can see metabolic acidosis obviously with other things as well. There's a few other things that I would put with tubulopathy. Okay, isosthenuria. Yes, they often have difficulty concentrating. Okay, proteinuria. So let's talk about whether or not there's proteinuria with tubulopathies. I often wonder if there is more of amino aciduria as opposed to overt proteinuria. And so what's the difference between those two? Obviously, instead of having complex proteins that are being lost in the urine, you're actually having just a few of the amino acids, and sometimes they can be fragments of proteins. And so the kind of general term that people often use when they're talking about tubulopathy, the term we learned in vet school is Fanconi syndrome, which I don't believe is the best term for this, but it is the term that we get taught in vet school. Okay, so these are all good, good terms. And I think that it shows that we honestly don't necessarily know all of the different components. It literally, if you parse out the word, it just means disease of the tubules, right? So so it really is a very vague term, and I'm not entirely sure. Ooh, mitochondriopathy. That's a good condition for this disease as well, or for this condition, I guess. So I'm going to exit that for now. I'm going to stop sharing for a moment. You guys are going to have to look at my face. So it is a general term. And again, when in vet school, we were taught Fanconi syndrome. The MDs don't really like the term Fanconi syndrome. It's mostly because there's a competing Fanconi's anemia, and so they don't really like the fact that it's two eponymous terms for different disease phenotypes. So they'll just say tubulopathy when usually they're not azotemic and they have some degree of glucosuria and some degree of amino aciduria, and then often some types of ion imbalances as well. So something is wrong with the tubular transporters. And like that last term was talking about, was maybe it's something wrong with the energetics of the proximal tubule. So maybe it's the mitochondria that have a problem and it can't supply ATP that are needed for tubular reabsorption. So there's obviously a wide general breadth of terms that can go with tubulopathy. This cat had chronic glucosuria, had some borderline to overt, well, I guess it would be borderline to true proteinuria based on a cat criteria. But again, the UPC was still usually less than 1. It was, based on that chart, it was, 0.6, 0.4, 0.7, something like that. So not truly like something that would make me scared for really bad glomerular disease. That being said, we have seen really bad glomerular disease with UPCs of 0.5. So it doesn't rule out glomerular disease, but it's not, a UPC of 10 this cat's hanging around with. But having chronic glucosuria in the presence of normal glycemia. And so all of those things, that's all of those things are kind of combining to this cat probably doesn't have normal renal function. But at the original time point in like in early 2000s, in the spring of 2024, the cat was not azotemic. Then he has an AKI event, and then the creatinine jumps up to 2, and then over the course of 2 months goes all the way to 13. So obviously something happened quite dramatically in those last 2 months of life. So I'm going to show you some histology now. And I should be able to launch the images. Let's see. I'm going to do... Nope. Okay, I'm going to do the... Hold on. I'm trying to figure out how I want to do this. Okay, do that. So again, you're going to be seeing my screen. I need to make sure my screen is showing the right thing, which is down here. Oh, hold on one second. Okay. So let me go to the H&E first. So you guys seeing histology images, big kidneys or kidney slices?
We are.
Okay, cool. Okay, so I believe this is one slice from each kidney. I could be wrong about that, but I think we got both kidneys for this case. And so again, if you have these really weird, confusing cases and you were able to get a biopsy, please reach out to us. We're still interested in investigating the cause or the types and the patterns of renal disease. So we're going to do what we can to help you. And it might be that it's only histology, and so it's a much cheaper diagnostic test than doing everything. But I hope everybody gets the perception that there's a lot of like bubbly spaces within the renal parenchyma, and it seems to be more prominent at the corticomedullary to deep cortex. Again, bubbly spaces, corticomedullary deep cortex, whereas the deeper medulla on the right side of the image, my right side, yeah, looks like it's not bubbly. It doesn't look like it has a lot of clear spaces. And there's mild dilation of tubules up in the outer cortex too, but the band right at the corticomedullary junction to deeper cortex is the most prominently affected. And Dr. McLeland is the cat kidney pathologist expert, and so she's the one that read this case, and she is here, right? I did see your face come or your name pop up, right, Shannon? Shannon, we're going to ask you to speak at some point, so you might as well unmute yourself. Okay, so let's see what these big bubbly spaces are. Did I hear your voice finally?
Yes, I'm here.
Okay, she's very shy. Okay, so these are very open, clear tubules, and we know that they're tubules because they're still lined by epithelial cells. And so as we start to see these spaces, we look and see some of them are just they're definitively dilated tubules. Like any pathologist would see this and say that this is a dilated tubule with tubular epithelial cells, and even the bigger spaces are aligned by often attenuated epithelial cells, but they're still epithelial cells, and they're kind of throughout. And sometimes we have a few cast material inside of them. Sometimes we have soft cellular debris like this guy. So this guy's a little cell that has detached and he is being floated out. Here are some more detached degenerating cells. Cells that still have viable nuclei. They look like they're actually probably normal cells, but they're being detached. And I don't have this as a quiz question, but does any pathologist want to speak up and say what the name of the term is when a viable cell detaches from a tubule?
Anoikis.
Okay, anoikis, Anoikis, also pronounced anicus. I don't know why, but I say anoikis because it says Noi, like noise. But I think in Greek you're supposed to say anicus. But so tubular epithelial cells can detach from the basement membrane and still be completely viable and get urinated out, and we can actually collect them in the urine and we can grow them. So you can actually see that tubular epithelial cell survives the entire transit, being stored in the bladder and being urinated out, and we can culture them. We can even technically sometimes do that when podocytes undergo the same process. So anicus or anoikis with podocytes, occasionally you'll catch podocytes in the urine and you can grow them. Okay, so that's kind of one feature that's going on in these tubules. Dr. McLeland, there is a certain type of inflammation that we talk about a lot in cats, and I'm going to put it here. And can you describe it for me so that I make you talk?
Sure. So it's, just chronic mononuclear, so lymphocytes and macrophages, occasionally some plasma cells.
And what are these guys?
So lipid.
Okay, cool. So the weird thing about cat inflammation, which I don't really appreciate in other species, is that when their tubules are injured, they often can release lipid from the tubular epithelial cell cytoplasm, and it could either go in two directions. It either could go into the lumen, or it could, if the base membrane of the tubule ruptures, get pushed out and, ooh, that was not supposed to happen, get extruded into the interstitium. And so sometimes you'll see these little lipid droplets hanging out within these mononuclear inflammatory cell infiltrates. On EM, sometimes you can even pick up that they are within macrophages. Sometimes you'll see lipid kind of like hanging out in between collagen fibrils. So it's actually the stuff like, maybe this stuff here is hanging out in between collagen fibrils. That's actually not, don't believe that. That's actually plasma from a vessel. So I lied about that one. But with EM, you can tell that the lipid is in the interstitium. It's either in between collagen fibrils. It's being phagocytized by the macrophages. And it's just a specific type of inflammation that cats do and other species don't seem to do. I don't really appreciate it with dogs and or people. And I don't appreciate it in the other, like the rodent species either. So cats are a species that likes to store lipid in their tubular epithelial cells. It is a storage place for their fat. And so that might be when they have a small AKI event or tubular injury event, that might be part of the pathogenesis of extruding lipid into the interstitium and then setting up this pro-inflammatory cycle. Because lipid is very pro-inflammatory. We know that, the pathologists all know that from like a sebaceous adenoma or a meibomian gland adenoma or something like that, that ruptures and the lipid from the sebaceous gland gets into the collagen of the dermis and incites inflammation. The same thing would happen in the collagen of the kidney. Interestingly, which I thought was, so saying that there's a lot of lipid in the tubular epithelial cells, this cat actually doesn't have a lot of lipid in its epithelial cells. Like here's a single lipid droplet, but a lot of times we'll see cats and it's just multiple vesicles all throughout the tubular epithelial cells. And this cat doesn't have a boatload of lipid inside their tubular epithelial cells. This stuff here is little bits of mineral. And so we have a little bit of like mineralization of the tubular epithelial cells, and every so often we see mineralization of the tubular basement membrane as well. And then I'm going to ask Haley, I see you're on this call. What is the term? I'm asking pathology's questions because these are pathology terms. What is the term when a tubular epithelial cell, like a proximal tubule, loses its brush border and becomes kind of flattened and attenuated like this? Do you know the term for that?
Could you just say like degeneration or something like that?
So degeneration would be the whole process.
Simplification?
Oftentimes, well, sorry, what'd you say?
Oh,
Tubular simplification?
Yeah, simplification. So that because what the simplification is a little more specific because it means that we have lost our very complex brush border, and now we've simplified the cell so it's a more basal, generic basic, basal cell, and it's not having to expend a lot of energy to maintain its brush border. And so one of the stains that we like to use for brush border analysis is the PAS, which I'm going to launch now. And so simplification is a pretty good classic term for loss of the brush border. And so we can see some cells still kind of have this like little bit of blebbing, but it's not even a great brush border. And a lot of them don't have any brush border. Now you can ask yourself, well, how do we know that this should have been a proximal tubule? Because like, what if it were a collecting duct? A collecting duct shouldn't have a brush border. And that's very true. But when you look and see how many have lost their brush border, and then only a few have remnant brush borders, you know that at least some of these have to be proximal tubules. Proximal tubules are like 65% of the tubular component in the cortex. And so just the sheer number that lack a brush border implies that it's been lost. And so some cells just kind of have like these little like remnants, and we're gonna actually see these on EM, these tiny little, small little structures, but not a great brush border. Let's see if I can find one that up in here that would be a good healthy. I bet I can't. Yeah, they're all kind of raggedy. And then, so we have dilated tubules, we have attenuated epithelium, we have loss of the brush border, we have sometimes thickened basement membranes as well. As you can see, this kind of like dark pink, like this one's really, really thickened out here, dark pink material on the basement membrane. We have inflammation, again, with a little bit of lipid hanging out in the inflammation. And then obviously I'm a pathologist that likes kidneys, so I want to look at the glomeruli. And looking at the glomeruli, this is an autopsy specimen, and it is a very good one. Like, it looks like it's very fresh, but oftentimes autopsy specimens will have kind of like a shrunken, collapsed glomerulus, mildly really wrinkled is probably the better word to see that. So see how these capillary loops are mildly wrinkled? We just presume that's because it's not a perfused glomerulus. It's not a living glomerulus, so it's no longer getting blood flow, and so it kind of loses the blood that would make the capillary loops open and patent. And so I'm never surprised if I see an autopsy glomerulus have that kind of uneven, kind of not even uneven is the right word, but like kind of a wrinkled outer contour. And so that's kind of going on with the glomeruli. I have one next question to make sure we're going on time. Okay, I'm going to launch. Let's see. I should be able to launch this. And this little thing needs to go away. I need to move this away. Sorry. Oh, goodness gracious. Okay, so that was our words. Okay, so then, so here's a picture of this cat's kidney. Hopefully you guys are seeing an HD of a glomerulus and a little weird thing next to it. Hopefully. Yes?
Yes.
Okay. Okay, so I'm circling this little weird thing. So what, and I'm going to show you another picture of it, and I'm going to ask you a multiple choice question about what that structure is. Here is the PAS of the exact same structure. So we've got a glomerulus, and then we've got that little weird thing next to it. And now my next question should be, you should be able to tell me whether you think this is a protein cast on a tubule, a globally sclerotic glomerulus, the edge of a normal glomerulus, or nodular interstitial fibrosis. Hopefully you can vote. I'm sorry, I'm having really bad spring allergies, but I always seem to have allergies anytime I'm presenting anything. So I think I just get like a Zoom allergy these days.
Are you willing to go back to the picture?
Yeah.
I might have gotten texted and I was not paying attention.
That's the picture. So the structure is this little thing, and I didn't circle it on this one. But I want to know what that structure is. Okay, we're going to see what the answers are. Okay, awesome. So most of the people voted for globally sclerotic glomerulus. It's probably not the edge of a normal glomerulus because it is kind of too wrinkled. And see all these little tiny little squiggly lines? Those were all once capillaries, and they lost their entire cellularity. So all of this stuff is just like used to be patent perfusing capillaries. And now we have these little kind of squiggly lines. The only reason I'm asking this, it doesn't really nothing to do with the case. But I want you guys as pathologists that are on this call and also clinicians to see that on an H&E, it's really hard to tell what that structure is. Like this could technically be a tubular cast on an H&E. And so it really is not until you get to the PAS and see that these are all little squiggly capillary loops that you would count this as a globally sclerotic glomerulus. And so why does that matter? When we're trying to assess kidney renal reserve, we're going to, in a biopsy, to tell you how many glomeruli you biopsied and then how many of them are non-functional, how many of them are globally sclerotic. And so if you only had the H&E, you might miss that guy and you would count too few glomeruli and you would count too few that are globally sclerotic. And so it would kind of throw off your calculation of how many of the nephrons have already been lost. And so just one more plug that if you are doing your own pathology, even just something as simple as a PAS can help you better estimate the number of glomeruli that are in a sample and then how many of them are quote unquote non-functional. Any questions about the globally sclerotic glomerulus? Okay.
No, Rachel, but can I make a comment?
Yes.
Just because I'm looking at it, it has absolutely nothing to do with the case, but it looks like both the arterioles were captured for the more normal glomerulus.
Yeah.
I just thought to point out is kind of cool. And then there's examples of some tubular epithelial lipid between 12 and 2 o'clock.
Yes, I agree.
Okay.
These little guys up here, yep. And this guy up there. My little zoom thing isn't there, but yes. So there are some vacuoles inside the tubular epithelial cells. Ooh, this might be a good brush border. So we finally have one of the tubules kind of at least having a PAS positive brush border. But most of them still are kind of, hazy, not really clear cut, but having some degree of lipid inside of the proximal tubules. And Shannon is right. When we look for vascular poles, we might only see one vessel. We may never see the actual vessel because it might be cut at a section that didn't capture the vessel. And then as far as I'm aware, there's really no way to tell which one's efferent and afferent. It's really even hard in human pathology. They used to think that one bent a little bit more, like I don't even know which one of those efferent or afferent had a different angle. But we really can't tell you which one's efferent and which one's afferent looking at it on a small animal specimen. And then see how much extracellular matrix. All of this is fibrosis, inflammation, and sometimes a little bit of lipid, but all of that is pretty marked fibrosis hanging out in the interstitial space. Which reminds me that now I'm going to go back to the yes.
Hattie had a question, or maybe
yeah.
not a question, but a comment that maybe you could address. She said she thought it seemed odd to have two glomeruli so close together on this histo. Thoughts?
We actually don't, that's not that common or not uncommon, especially when they're scarring down. But every so often, Hattie, we can actually see, I actually have a really good picture of it. I'll have to send it for something, but it was a large glomerulus and it had a patent tuft, like a patent tuft. You can have twin glomeruli. That's my point, is like you can have two separate tufts inside the same Bowman's capsule. And I've had one case where I had a really gorgeous tuft. And then the little baby that was the twin glomerulus, he died and he was sclerotic, but they were very separate structures. So it was a kind of a big Bowman's capsule, a normal glomerulus, and then a little sclerotic baby, twin glomerulus at the side. And it reminded me of like the stories when you say you have twins in utero and one of them, takes over and becomes the dominant twin. It reminded me of that in my brain, but that's because I like horror stories. But yeah, I'm not surprised when I see that. The distribution and the of glomeruli can be haphazard. Okay, so that's bringing me to the trichrome stain. I'm trying to make sure I'm staying on time. Okay. I hinted at it a little bit with the PAS, talking about how much collagen there was in between the tubules. And so Dr. Quimby and we had a paper where we looked at the distance between the tubular epithelial cells and then the peritubular capillaries, and so you really want your tubules to be back to back, and also you want your tubules to be really close to their blood supply, which is the peritubular capillary bed. So Renee was the primary author on it, and so we looked at, and in a different set of cats, but we tried to see, is there a difference between the interstitial fibrosis and how much that might separate a tubule from its endothelial cell IHC stain, to show that that in CKD, one of the pathogeneses is that too much fibrosis gets laid down and it separates a tubule from its blood supply. And it's really even hard in these for me to find a true peritubular capillary. That's why with the paper we did with Quimby, we had to stain them. We stain, usually in these like really chronic cases, to stain them to see how close the peritubular capillary bed is from the tubulopathial cells. But I think as I scan around, you guys can appreciate dense collagen kind of piling up in between the tubules. This stuff here, this pale blue material, is actually thickened basement membrane of the tubules. So on the PAS stain, it was really dark pink, and in the trichrome stain, it's kind of this pale blue. That's why it can be very difficult for automation and AI to recognize the difference between the tubular thickening that happens with basement membrane thickening and interstitial fibrosis. And so both of these contribute to the space between the tubulopathial cell and its peritubular capillary bed, but they have a different tinctorial change. And so it can be very difficult for that to be assessed unless you have a person that has that knows they're both separating the structures from one another. Okay, again, paying attention to the fact that the tubules that are really, really dilated are at the corticomedullary junction. There is also dilation at the cortex, but it is less pronounced than the stuff at the corticomedullary junction. The Jones was kind of boring. We only look at a Jones for glomerular capillary walls. I mean, there's a little bit of wrinkling, but again, we said it was an autopsy specimen. So nothing really that exciting with the Jones. And then we had a Von Casa, if I can load it. So Von Casa is to look at the mineralization. And interestingly, there really wasn't a lot. Is that correct, Shannon? I don't think we actually saw much, right? I think we took a couple pictures of.
I didn't report on anything, so.
Okay.
Uh.
Yeah, I think because we have been looking at a lot of mineralization with CKD cases from cats, and what we normally see is pretty good staining in the renal papilla, and so none of this really stained positively, but I think there were very few tubules like I showed you in that regular, yeah, here, like there's very small bits kind of with those epithelial cells that are sloughed. Like these are probably tiny little bits of crystalline material that are being sloughed from the tubule, from the dilated tubules, but it's not the kind of typical pattern we have been seeing in many of our CKD cats. That's non-specific dirt. Okay, boring. Okay, so let's go to the EM, which I have somewhere pulled up. Let's see, here it is. Oh, it's because I have to go all the way down. Okay, hold on. I apologize. 0187. Okay, so we did electron microscopy because we were interested in the fact that this was such a weird kind of pattern of tubular dilation, and we're like, is something wrong with the tubular basement membranes? And so we specifically looked at the tubules for this case. I even think that this was the case where we actually couldn't get glomeruli. The glomeruli were just all shrunken, and we weren't able to get really good glomeruli anyway, but that was fine because we weren't really looking at glomeruli. We were looking at the tubular epithelial cells. And so I'm just going to quickly, because we have a couple of questions about the tubular epithelial component in the EM. So I'm going to scroll through these if I can. Oh, I think I have to do this thing. But when you're looking at tubular interstitium, and the whole reason I'm scrolling through these is to show you that there is a lot of tubular interstitium when you do an EM grid. And it can be helpful sometimes because you can actually say, oh, I'm looking at a collecting duct, or I'm looking at a proximal tubule, and I know where I'm, what structure I am. I have a lot of experience in this. So this is a collecting duct. I can tell based on the fact that there's only a few tiny little microvilli and the flattening of the epithelial cells. But then this is probably one of those injured, simplified proximal tubules. And so you can kind of guesstimate which tubule is which. But the other thing that we like to look at is fibrosis and how much, as I mentioned, fibrosis would separate a tubule from its capillary. You really want them to be immediately adjacent to one another. And so having any kind of space from that would be a distance that oxygen would have to cross, or anything that's being reabsorbed would have to be crossing back, can be difficult or can be hindered by that distance. So those are just kind of all the images we got with the tubular epithelial cells. Sometimes you had some thickened, wrinkled basement membrane. And I'm going to now, any questions? I'm going to launch a couple of EM questions, if that's okay. Okay, so that was our picture from our glomerulus. Okay, so then that was our answers. Okay, here is my pick. I think this one you can only do if you are on a laptop. And see if, I just want to see if this works. This is more of just to see if it works. Can you guys click on what you think might be the peritubular capillary? I'm not sure. Oh, good. I'm not even paying attention. I'm looking at a text. Sorry, I'm the worst. Okay, awesome. Great. You guys all saw the peritubular capillary. I hope that the red cells helped you. And so we need a lot of measurements to see how these would be separate from one another. And I honestly don't know if it means that they have to be millimeters separate for it to be significant, if it can be microns separate for it to be significant. And then also measuring the separateness is very difficult, because remember, these are intertwining tubular structures. So the peritubular capillary is also a tubule. It's a capillary tubule. So it's intertwining around the proximal tubule and all the distal tubules as well. So even though we see a lot of distance in this one cross section between the guy that's up here at the top left-hand corner and the peritubular capillary, I can't guarantee that they don't get closer further down. So it is a great thought, and it helps with us to describe how this pathogenesis can occur. But again, measurement is very difficult because they are three-dimensional structures. And so I can't guarantee that they don't get closer and he can perfuse, further down the tubule. Now, does it mean that this particular epithelial cell is kind of screwed because he's not getting the blood? That's possible. But we really would like them to be closer, much like this, this little structure here. So that's kind of interesting. And then I think my next question is, okay, so one of these is from our patient and one of these is a normal tubulonostitium. And I'm going to launch a question in just a moment, but I want everybody to not look at their phones like I'm doing, and see if you think A is the normal or A is from our patient versus B. And I'm going to launch the question. So do you think A, the left image, was the patient image, or was B the patient image? And I might have to go and let's see. Hopefully people are choosing. Okay, awesome. Okay, great. So most of you guys guessed that B was the patient image, which is correct. So let's look at and sadly I didn't do a whole picture of just this, but what can I do? I know what I can do. Hold on, this is what I'll do. Okay. Now you guys are just seeing it in a weird format, but that's fine. Let's get rid of you. Okay, so here is what we think normal, healthy proximal tubules should look like. So there are no more questions. You guys all passed the question portion, and we will ask for feedback about if you think these are stupid questions or if we should not have user engagement. I like them because they give me a little bit of a break to take a breath. But I'm going to show you what's normal about this particular tubular interstitial profile. So here we have good brush borders. See how it's this kind of like slight gray? All of those are microvilli that are lined up parallel to one another. And oftentimes you can sometimes you don't even see what's in the lumen. This is probably an epithelial cell that's kind of squished up from further down. So oftentimes the lumen is even full of material. And that's true also in the histology. I think you guys have heard me say before that in a good, healthy proximal tubule on histology, oftentimes you can't really even appreciate the lumen because that brush border is so thick and projecting towards the lumen that you don't see the empty space. And so all of this encircling around is tubular epithelial cell brush border. And then you have your really good columnar epithelial cells. Sometimes you catch a nucleus in the epithelial cell. Other cells, the cell is so big, you're not capturing the nucleus in this particular cell. All of these kind of dense gray things right here that are kind of linear are really huge mitochondria. The proximal tubule needs so much energy to drive its transport systems. It needs a ton of mitochondria. These out here are also mitochondria. This is another really good adjacent proximal tubule. Here's his brush border. Here are all of his mitochondria. Here's his little nucleus. These little darker black, like kind of darker gray things are little vacuoles. Those are probably penocytic vacuoles. So the tubule cell is drinking from the lumen. It's taking little sips of what's in the lumen and it's going and processing back into the tubular epithelial cell cytoplasm. And I actually do think that this is a dog because I know what picture I took. So this is a dog. But there's a few tiny little electron-lucent vacuoles as well. Your tubular epithelial cell, your tubular base membrane should be fairly normal thin line. And see how here's the peritubular capillary for these guys. See how freaking close it is to the proximal tubule? That's what you want for a healthy communication. Like there's no boundaries between the two. They are really honestly oxygenating the tubule and then reabsorbing whatever the tubule gives to them. Here's another little peritubular capillary. This guy down here is probably an endothelial cell of a peritubular capillary. And then compare these tubules with this great brush border to this guy over here who doesn't have a brush border. And this is a cortical collecting duct. And so he lacks his brush border. He has these tiny little, like a few tendrils that are out there sensing a few things, but does not have the great brush border that the proximal tubule does. And so that's what you want to see for healthy tubular interstitium. We obviously don't see it for this cat. So back to the cat. I don't know, other than we just kind of did a descriptive diagnosis that we had these weird dilated tubules, and that seemed to be the primary problem, and that they were in that like location, not necessarily in the outer cortex. But also the comment which we clarified was that we had them go back and trim more papilla to make sure the papilla wasn't necrotic. Because obviously if you had papillary necrosis, we would expect some kind of obstruction all the way up to the outer portions of the kidney. But if you remember on the histology, the inner medulla / outer medulla actually looked pretty normal. And it really wasn't dilated until you got to that region of the corticomedullary junction and the inner cortex. We gave him a diagnosis that was descriptive. And Dr. McLeland, please tell me if you have any other comments about this case.
No, you did great.
Okay, so I think we've had one more case fairly recently from Dr. Quimby that had a similar kind of pattern of corticomedullary dilation. And so, but I think that one actually had a little bit more involvement of the cortex as well. And it was a cat. So we might want to compare those two and honestly kind of go back and see of our kind of microcystic changes that happen in cats. Are there others that seem to be in that corticomedullary region? I will say that having looked at a lot of cats with CKD and kind of end stage, sometimes, and Shannon can verify this too, you might look at a case and that whole corticomedullary region is fibrotic and you don't even see any tubules and it's just collagen. So something is very difficult or different about that region that could either lead to obstruction or dilation or just complete overt fibrosis. And so, but trying to tease out what would do that is difficult. No, I don't know if that's happening there in particular. I don't know. Dr. Shropshire. It is something that we probably need to be better about qualifying and quantifying. And Dr. Hokamp did nudge me a little bit today about making sure we get cats into the renal path atlas, which I need to do. And so maybe that'll be something we kind of look at to see. It's not something I see in that region necessarily with dogs. it is kind of a cat thing. I think Shannon, you can verify that every so often you'll get a cat with really bad CKD and it'll just be almost like fibrotic in that region. And so we might need to dig into why that might happen there.
Yeah, I mean, I agree. I mean, with this, are you speaking just in the cortical medullary junction or just the cortex?
Usually it's like kind of corticomedullary to like inner cortex, and then like the outer cortex seems to be more just inflammatory.
Yeah.
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 So yeah, it does stimulate us to get cats at least documented. We're not gonna have the answers, but at least we're gonna have examples. And then maybe it is some kind of, I mean, this cat's 9 years old, so it's probably not some kind of genetic like hereditary thing. But there obviously is something weird about its proximal tubular function that led to all of the glucosuria. And I guess one more question I didn't ask that I should have asked Mario. You guys never really sent it to analysis to see if there was like any other like amino acids that were in the urine in addition to the glucose.
Yeah.
I think there was kind of discussion about sending that test, but my understanding is that it didn't happen. But yeah.
Yeah. Okay. So maybe, yeah, and it's obviously it seemed like you guys kind of got it when it was already getting ready to decompensate, and it did decompensate, so it was really kind of hard to start looking at that point because it was by that time that cat was already azotemic. Okay. Well, please let me know if there's any other questions you have for this case. I'm gonna wrap up 5 minutes early. We will have, oh wait, like let me look at May. Hold on one second. May. Oh no, we can have rounds. Yes. It'll be the 20th. And so I'll send out an email again at the beginning of the month, ask for cases to be requested. And we can go from there and see what kind of topics we wanna have for discussion. Is that okay? Okay. Thanks, guys. Jessica, can you
Yep.
stay on, or is it better probably to Teams call me to cut in that cystic case? That might be
Oh,
better.
right, because this is on ACVNU. Yeah, we
Yeah,
probably
let's-
should do that.
Okay. Thanks, guys.
Bye.